just as a reminder, this is a moderated session. I'm going to go through these questions to see which is most applicable to most of the patients. I'm sorry if I don't answer one of your questions here, but there are the disease-specific breakout sessions towards the end of the day. So that's an opportunity for you to ask a question yourself directly to the panelists. All right, so I'm going to start with the one that I can read the best. Some of you must be physicians because I can't read the handwriting on some of these. Okay. All right, so I think this has actually happened to be luck of the draw, a good question to begin the Q&A session asking. So I might call on some of you on this question. I'm going to call on Dr. Hoffman for this one because this question actually is directed about disease progression. The question doesn't specifically ask how do you define disease progression, but I would like to introduce that myself and say, how do you define disease progression in ET and PV? This is specific to ET-PV. And will interferon treatment help slow progression from ET to PV?
Well, as I tried to indicate to you in my talk, I'm in ET and PV.
I don't think it's on.
Sorry. Can you hear me now? Yeah, so ET and PV are what I would call proliferative myeloproliferative neoplasms in that blood cell production is effective. You have increased numbers of cells, either platelets and or red cells and also white cells. And as, yeah, sorry. Yeah. So can you hear me now? Okay. So ET and PV are what I would call proliferative myeloproliferative neoplasms and also the early forms of myelofibrosis where you have increased blood cell production. That means that blood cell production is effective. You have a lot of erythroblasts, megakaryocytes, and white blood cells in the marrow. And as the disease progresses over decades, frequently, hopefully decades, and irrespective of the therapeutic intervention, whether it's phlebotomy or whether it's ruxolitinib or whether it's interferon of hydroxyurea, a switch is sort of turned off. And that hematopoiesis, the effective blood cell production, becomes ineffective frequently. And basically, at least this is the way I conceptualize it, and basically you develop a phase where you still have a lot of bone marrow cells in the marrow, but the bone marrow has become more inflammatory, as has been shown by Angela and Dr. Hasselbeck. And that creates sort of the perfect storm, which essentially leads to further promotion of the proliferation and enhancement with more complex microenvironment, increased numbers of malignant stem cells. So if, like for instance, if you have essential thrombocythemia and you're just being followed with aspirin therapy and you're running around with a platelet count, let's say, of 800 or 800,000 or a million, and suddenly your platelet count, irrespective of the treatment, you're on no treatment, goes down to 150,000, that's a problem because that indicates that you're now ineffective. You have lots of megakaryocytes in your marrow, but you're ineffectively producing, and that means that something has evolved in the disease. That's probably a signal for doing next generation sequencing to see if you have additional mutations or cytogenetic analysis to see if you have new cytogenetic abnormalities. Similarly, let's say in a situation, although in this environment people don't want to treat patients with phlebotomy alone, let's say we're treating patients with rusfertide and somebody has a steady phlebotomy requirement. If suddenly, if that patient stops having a phlebotomy requirement and actually becomes anemic, that's a very bad sign. So if you complain about having a phlebotomy requirement, I often tell the patients, hey, that's terrific that you need a phlebotomy because your erythropoiesis is essentially effective and it shows that your disease has not evolved, irrespective of the mutations. This is based totally on clinical findings. So the question is, can you delay this process with the use of interferon? And obviously there are a lot of folks in this environment here at Cornell and in Denmark and in Europe that feel that you can. And I think that's going to require a big study with a lot of patients. And I'm not sure definitively if we're ever really going to know that, because the National Institutes of Health and the National Cancer Institute, they're not going to fund that study. Pharmaceutical companies are not going to fund that study because that study is going to take decades to do. So we're left with basically the opinions based upon data of people, and there's a division of opinion. And I think it's a question mark. I mean, to be totally honest with you, I would surely not discount, the opinions of my respected colleagues, but I have some skepticism whether it really prevents evolution of the disease. Because unfortunately, for instance, like people here spoke very aggressively about the drop in JAK2 V617F mutations with interferon therapy, but there's similar results with interferon therapy if you have a calreticulin mutation, but the mutation doesn't drop. Mm-hmm. So the issue is I don't know what that means. And I think that we really need to take a step back and say, probably in the present environment, we're not going to be able to define this, and that the two drugs, based upon the patient's demographics, how old they are, whether they're in their reproductive ages, whether they're depressed or whether they have comorbidities, personalized approach is probably the most important way to deal with this in a very even-handed way, rather than getting, very emotional about it. To say, there are 2 or 3 options. And my hope is that this will become an archaic discussion with the new therapeutics that are going to be coming down the road. So that's how I look at it.
Thank you, Dr. Hoffman. I think the highest level of evidence, I think this is what Dr. Hoffman is also getting to, is the highest level of evidence is a randomized clinical trial. That's a study where you say you have a group of patients with a particular disease and you randomize the patients to either a treatment drug or a control. Control can be standard of care, and the intervention can be any drug, perhaps interferon. So the challenge in PV has been that randomized clinical trials do not use progression or progression-free survival as a primary endpoint to get the drug approved. And so ultimately, the more definitive evidence is always a randomized clinical trial. That being said, there is certainly the data that Dr. Silver presented, not only our retrospective data, which again is not a randomized clinical trial, but there is randomized clinical trial data from the use of ropeg interferon comparing to hydroxyurea. So I think that the second component of the question, which I'll direct to Dr. Silver, is you did talk about PV and the use of interferon in PV. What do we know about interferon in ET potentially reducing progression? Mm-hmm. I can certainly speak for myself is that I'm not sure that the data is fully mature about the interferon's benefit for ET in preventing progression. So what are your thoughts about using interferon in ET, whether it would prevent progression, and also how does the molecular characterization of the ET actually potentially influence the use of interferon, whether it's CALR or whether it's JAK2? And I think this is a question to both Dr. Silver and maybe Dr. Hasselbach after we hear from Dr. Silver.
Hans, you want to answer that first?
Yeah, for sure.
And also triple negative.
No, I'm being polite. I know what I'm going to say.
he knows the answer.
Do I start?
Yeah, go ahead.
Okay.
He's our guest.
Yeah. First of all, I think that that is also the challenging, but also highly inspiring. That we have different opinions on this. On the issue if interferon is able to be disease modifying, and for sure interferon alpha is disease modifying in terms of inducing a normal bone marrow and in terms of normalization of the blood cell counts, of course, and also in terms of inducing low burden JAK2 from, for instance, 60 to 70 to below 1. That is my first point. The second point is that we are entering a new era where we can discontinue. And I am a supporter of discontinuation therapy, where the patient can pause for 1 or 2, 3 years. That is, it is not a dream in my outpatient clinic. That is reality, and they still have normal cell counts. and they have a low burden JAK2 that gradually then increased to 5 or 10%, still with normal cell counts, but then I reinstall interferon and have a rapid decline in JAK2 allele burden. To me, it is so meaningful to treat the patients in this manner, to treat as early as possible a cancer. And just to what is happening here? Okay. Yeah, okay.
No, speak. I just moved it away a little bit.
Yeah, okay. But just to conclude that I'm a true believer.
Maybe we should turn this
that I think that I must not talk anymore. So thanks so much. It has been wonderful to join you all. Silver. It's your turn.
I believe that, as Dr. Hasselbach mentioned, and as you heard today, the MPNs are malignant diseases. And many of us in the older generation treated before MPNs became popular and so many drugs became available to treat. We also treated many patients with solid tumors, such as breast, lung, pancreas, and so on. And I'm board certified in oncology. So one of the things we learned early is that you treat cancer early. You don't treat it when we have to refer patients to our colleagues for transplantation. That being said, there is abundant data in the MPNs, which is certainly mostly phase 2. Phase 2 means, as Dr. Abu-Zeinah said, there's a lot of single-arm studies indicating that interferon is life-saving. And in this room, as I mentioned in my talk, we have many patients who have been on interferon 25 and 30 years that I have treated, now Dr. Abu-Zeinah is treating. So there's no question that that drug works, because I have been of the generation, and I've gone over the phase 2 data. We've talked about the polycythemia vera study group, indicating that phlebotomy per se is not life-saving, and in fact adds to the morbidity and mortality of the disease. And I find it difficult to understand why my distinguished colleague and dear friend, Dr. Hoffman, doesn't understand that. Now, I would also point out that
I think this is where
certain studies are known as...
This is friendly fire.
Certain studies are known as parachute studies. You can take two people up in a plane, and you don't have to randomize them to show that a parachute works. And that is really,
I think,
what interferon does.
I think, Dr. Silver, on the topic of ET, I think this is where I'll interrupt and maybe direct a question towards Angela, actually. For ET patients, I get this question a lot in clinic, and we saw Dr. Scandura presented that if you're very, very low risk or even intermediate risk, probably all you're going to be recommended to take is aspirin or no aspirin. And so the patient will say, well, what can I do? Because I know I have a disease. I know it can progress. What can I do about it? And I think that's where, things become, dietary habits become an interesting topic to discuss. Exercise, lifestyle modification. What are some things that are non-pharmacologic that we can do? And that ties into one question where a patient or somebody was interested in knowing the results of the inflammation data that your study had shown. And granted, that was only a feasibility study. How do you think patients can participate and think about dietary interventions, whether it's your study or through different means? How could they be more proactive about taking care of their own health?
Okay, so I can try to address that. I don't think it's rocket science that eating a good diet is going to be beneficial for one's health. And I think in particular with patients with a chronic low-grade inflammation, such as myeloproliferative neoplasms, or even a precursor condition that's now called CHIP, basically having mutant cells in your blood but no blood count abnormalities. And those conditions are known to be also associated with chronic inflammation and increased atherosclerosis. Or maybe I'll just use this. So that is where I think that diet and other lifestyle interventions can be most helpful. You specifically asked about how does one go about, improving their diet. One doesn't need to participate in a clinical trial or a study to improve one's diet. Also, someone doesn't necessarily need to spend money to see a registered dietitian if really your budget doesn't allow for that. I mean, there's a lot of information on the internet about healthy diets, books. So I think just incorporating a very healthy diet, which when we did this study, I assumed that everybody had a baseline understanding of what a healthy diet was. And I think for me, that was one of the most eye-opening things about some of the lack of knowledge of the general population in terms of what a healthy diet is.
Can I just add a point about that? As a former home economics teacher in high schools who was laid off all the time because nobody ever wanted to take stitching and stewing, I just want to refer people to good sources of information for nutrition. EatRight.org is an excellent source from the American Dietetics Association for good nutrition, the Mediterranean diet, DASH diet, whatever type of healthy diet you want. There are lots of resources out there, many not good.
Yes, I agree. So that's what I was going to say. There's lots of resources online, but it's very difficult to, triage what's good and what's bad. So I think it's easy for me to say just eat a healthy diet, but if you don't know what that is, then you can't follow it. So I would say go to reputable websites that are free to look at, or go to the library and get books if you really don't have the resources with an internet or able to buy books on your own. Is that that's
Thank you. I think that covers at least the question that was asked here. Well, maybe so if a patient wanted to enroll in your study, how do they have to see you?
So at the present time, we don't have anything open because in order to do a larger study, we need money and trying to get a grant through the NIH, which unfortunately, preventative and diet studies may not be on the top of priority for the NIH at this point in time. So hopefully we will get some funding to open the studies. At first, we were going to do our much larger study as a totally online study. However, because we really do feel that it is important to get basically fresh blood from people, we really do want people to be able to actually travel to Southern California to participate in a study.
Thank you, Angela. Okay, so let's talk a little bit about about mutations in general. So when do we profile for mutations? Is that a standard clinical practice, or is it just a research tool? I think this kind of ties in nicely to thinking about myelofibrosis, whether it's the early treatment of myelofibrosis or the later treatment, which comes to transplant. So maybe we can hear from Dr. Tamari first about more advanced myelofibrosis where mutations can be helpful in making decisions for transplant, and then we'll move on afterwards to talking to Dr. Silver about early myelofibrosis treatment.
So can you hear me? So I think this is an excellent question for which I don't have an answer. The simple answer is that I do usually check for mutation where I see a change in the clinical behavior of the disease. But I also must say that rarely does change or appearance of a new mutation, if it doesn't correlate with any clinical presentation, meaning there's no change in blood counts, there's no change in constitutional symptoms, will make me recommend a transplant just based on the presence of mutation. So with that, I'm going a little bit back and forth in my mind, and I think that actually talks more for the patients with low risk disease, where we say, okay, we monitor, but how do we monitor? And we also talk about the importance of recognizing when the disease starts behaving in a different way, but maybe waiting for the anemia is too late. So I think this is certainly something that would be great to study over time, again, I think we're going back to the importance of practicing based on data, yet the difficulties with lack of funding, the need to really do these studies over a big time is a barrier for us. But yes, I think that a prospective study with patients with myelofibrosis, over time learning what's the correlation between mutation and the clinical presentation is something that would be very, very helpful.
I agree, and I also think one of the most challenging things about myelofibrosis, it's a very heterogeneous disease, and that heterogeneity clinically is not always explained by the mutations. In fact, it's rarely explained by the mutations alone. So there's a lot more to the story about what causes myelofibrosis to be more aggressive and what makes us decide on a watch and wait approach versus a transplant. Totally different things on the other extremes. And so in kind of moving from deciding on transplant to diagnosing new myelofibrosis still early, you do have a mutation profile, you do the testing that's necessary. So what are some of the questions that you would have to ask to decide whether interferon, for instance, is useful in the early treatment of myelofibrosis, or whether a patient would benefit from a standard of care or a clinical trial? Why not go to a clinical trial directly? So that question is to you, Dr. Silver. Tell us a little bit about early myelofibrosis, perhaps a new diagnosis. How do you make the decision on interferon versus standard of care, JAK inhibitors, or clinical trials?
So I didn't really answer the first question as adequately as I wanted to. But the question of next generation sequencing is really very, very important. And Dr. Ann Mullally and Dr. Hasselbach just published a very large study, which was sponsored by the MPNRF in Chicago, indicating that next generation sequencing is very important in following all patients with with myeloproliferative neoplasms, particularly myelofibrosis and, of course, polycythemia. And they indicated that if you have one abnormality, even ASXL1 or EZH2, that may not be bad, but if you get 2 or 3, that may even precede the development of other clinical abnormalities which you can not detect in the bone marrow morphology or clinically or whatever. And that may be a chance for our transplanters to have an easier solution to identify patients who are at risk. So we recommend, for example, all patients at Cornell have a next generation sequencing when first seen, and depending on those results, they may have it repeated at a year or 2 or 3, or depending on the results. Now, as far as early treatment, I know Dr. Hasselbach agrees with me independently, and as do the others in Europe. We have established histopathologic criteria and changes under the microscope that you can see in interferon-treated patients who have early myelofibrosis. And it seems to us that and those patients that have been shown to be symptomatic, this is not asymptomatic disease anymore. That was first identified by Dr. Mesa and his group, and everybody has confirmed that. So these are not symptom-free patients, these are patients with symptoms. Therefore, we also have a drug that, when properly used, has very low complication rate. It seems to us, therefore, that those patients, even though would have a controlled clinical trial, in the absence of that, it seems to us there is sufficient evidence, histopathologic, clinical, symptomatic, very important, that it's better to treat this disease before you have to discuss and refer a patient to a bone marrow transplant. Now, so we treat our early myelofibrosis patients, unless contraindicated, with interferon. That's the cellular phase of myelofibrosis. Interferon does not work, we all agree, when there's extensive myelofibrosis. It's too late. Now, with regard to the question that was asked with ET, that's more complicated because you have to consider the risk factors, the age of the patient, whether a patient has hypertension, cardiovascular risk factors, etc. But I believe the data is accumulating in large phase 2 studies that patients who have cardiovascular risk factors, hypertension, coronary artery disease, diabetes, those patients are at risk for thrombotic events. and particularly if they're JAK2, those patients with ET probably should be treated with calreticulin. It's a little bit more vague, and although, as Dr. Scandura pointed out, those patients with calreticulin have more of a tendency to develop myelofibrosis. So that's a very interesting question.
Thank you, Dr. Silver. Some questions I think are better suited for the breakout sessions. Somebody asked about MPL mutant ET and wanting to hear more about that. So I think perhaps we can address that in the breakout session. One question I'll direct to Dr. Hoffman. So Dr. Pamaraju mentioned that overall survival was for the first time an endpoint in a clinical trial. Is that limited to myelofibrosis trial where overall survival is shortened, is expected to be shorter? And I think my addition to that question is how do you, and you mentioned this earlier, so how do you envision us moving forward with clinical trials for PV and ET addressing the question about survival, whether it be thrombosis-free, progression-free overall survival? Do you think it's ever going to be feasible? Is there a way to design these trials such that we can actually identify drugs that can prevent progression?
I don't think the folks over here heard you. Could you repeat the question?
Maybe Dr. Hoffman, if maybe Dr. Hoffman can recap. So the question is more about clinical trials for ET and PV and how survival can be incorporated as an endpoint, because it's an important endpoint in trials that are intended for ET and PV, which are considered more indolent diseases than myelofibrosis.
Yeah, I think that's a really tough question because, the average survival of patients with ET and PV with appropriate treatment today is measured in, decade and a half. And it's difficult to keep individuals and physicians focused on long-term clinical trials. So that's a real dilemma. I think that's a real big problem. For me, we have drugs now that control hematocrit levels. We have drugs that control platelet counts. And we have drugs that reduce Sorry. I guess I have to stand up. We have drugs that control platelet counts. We have drugs that control hematocrit. We have drugs that control white blood cell counts. And we actually have terrific drugs that control symptoms. They last for a limited period of time, but they do act, and we have multiple. To me, the real question is overall survival. We want to cure this disease. So that's going to require what Ronnie was talking about is essentially stem cell replacement therapy. And if we can do that medically, that's far better. And putting her out of business, it would be much better.
I would be delighted
she
to be
would
out
be
of
happy. So, that's really what it comes down to. And it's probably going to take, first of all, when I say this, I don't say this lightly because I shake in my boots every time I tell somebody to go for a stem cell transplant, which I do about once a week. But, because I know that at the other end, 20% of the patients, that's basically 1 out of 5, is not going to make it during the first 6 months. So that's an awesome responsibility. And one should not minimize that. That's really important. So that's why we're really sort of trying to accelerate this drug development. And thank God we have the backing of pharmaceutical companies, which, as Dick will tell you, 30 years ago, the pharmaceutical companies didn't want to look at us. Right, Dick?
Absolutely.
Right. So, that's a big force. Pharma really has seen this as a chronic disease. We live in a capitalist society where they can make money off of you guys. That's putting it in an extremely crude way, but that's reality. But, the focus is, do we have the wherewithal as a community, as a patient population, to stick to a protocol to determine whether these proliferative diseases will prolong survival? And that's a question mark, because it's really hard to do that, as you well realize that. We have a less mobile society now because of COVID and financial disasters. Maybe it'll be possible. But people want to jump to the next drug. And, we're not taught. We have diseases that last long periods of time. This is not like metastatic. This is not like early stage breast cancer where you can go on for decades, or metastatic breast cancer where you can die in, a year and a half. These are diseases that last decades. So that's why all the studies are being done in myelofibrosis, because you can determine overall survival, because if you fail a JAK2 inhibitor, you have a really rough time. You have 1 to 2 years before your disease evolves. That's why that's why the studies are done. They're done for financial reasons and to get an idea that it affects overall survival. But the stem cell therapy that she talked about is the only curative treatment. That's it. But it's dangerous, as Ronnie knows.
Right. No, I definitely agree. I don't know if I'm not here to disagree. I agree with Dr. Hoffman, and I think that every patient that we take to transplant, we really think very, very carefully. And I think it goes again to my last point. It's the timing of transplant, taking the right patients, because it's not only about survival, it's also how do patients do after transplant? Because to keep someone alive but with another chronic disease, then we failed. And for that purpose, yes, if we have a treatment that can really replace the bone marrow, recover the bone marrow without all the complications of getting immune system from someone else, that's what I look for. That reason, I would be happy to be out of business. But at the same time, our goal on the transplant side is really to make this treatment better tolerated, less complicated, and improve on all the complications that come with that.
Excellent.
I don't want to discourage people from coming to the PV section, but we're very fortunate in having an absolute wonderful example of a survivor of transplant who had myelofibrosis. So he's came up specially from Florida. Nick, are you here? And he's going to talk to you folks with myelofibrosis this afternoon.
Okay, so I think that's all very interesting. I have a lot of questions myself, but in order to get through some of these questions, I think I'll pick a question that is maybe a little more straightforward to Dr. Hasselbach. Should I take probiotics? And what do you think about, in the context of the microbiome and MPNs, what do you envision happening in terms of regulating the microbiome? Are there interventions that are being more gut-specific or gut-targeted rather than MPN-targeted that could perhaps help the MPN? And I think a good example of that is how you alluded to the fact that statins, which have anti-inflammatory benefits, could potentially benefit MPN patients. And there's even data out there for metformin, which is a diabetes drug. So how do you envision targeting the microbiome, and where does the kind of taking probiotics fit in?
It allows me to speak? Yes, it does. I think that first of all, your question, I cannot answer it, but I can say that when we have an agent that is able to induce a normal bone marrow, and again I refer to interferon alpha, and also what we find here in our preliminary data on microbiome investigations and MPNs showing that the interferon group is featured by a near normal microbiome, very similar to healthy controls. And also I think that it's in mice models showing that interferon alpha tightens the tight junctions that prohibit intestinal leakage of substances to the systemic circulation, giving rise to an inflammatory state. I think that there are so many meaningful factors and arguments that interferon is one of the agents. Saying that, it is also very important because I think that I actually shifted very rapidly in my talk, but I had a slide showing our data from Denmark where we have shown that citizens, patients being on a statin, that a statin protects prohibits MPN development. Using a statin protects you from developing MPNs. I think that this is really a remarkable finding. And also adding to this, when we are analyzing our patients and they increase steadily, having obtained minimal residual disease on long-term interferon alpha treatment, being featured by a normal bone marrow, normal cell counts, and low burden JAK2 decreasing from JAK2 allele burden at diagnosis of 70 to 80. I dare say that we have an agent which we should use as early as possible to a cancer that we for sure know, as all other cancers, steadily develop clonal expansion, clonal evolution, subclone formation, and then we have the ultimate stage, which you can compare to a metastatic stage, actually, the myelofibrosis stage. And at that time point, there's no return for most patients.
Thank you, Dr. Hasselbach. I'm actually interested to also hear from Dr. Fleischman on the same topic of statin use and anti-inflammatory drugs, and also ruxolitinib in reducing inflammation. How can you measure inflammation? I think that's another question. So
that's a very, very good question, and something that I'm struggling with, because as you can see in our diet study, we so although we used a very sensitive panel of inflammatory cytokines, which included, I think, a panel of 20. Many of them were below the level of detection, so basically so low that it was undetectable, or at least. So it's clear that the patients have inflammation, but exactly what measure, sort of what clinical measure to use to sort of quantify their inflammation is a very good question. We thought that maybe the CRP, high-sensitive CRP, would be an easy way of doing it because it's a very readily available clinical test. But in our small cohort, did not see any. We're surprised at how low our CRPs were in our MPN patients. So that is a very good question about how to measure it. I don't have a good answer for that. Statins, I'm intrigued by the data on statins, and statins have many benefits. So I really don't have anything intelligent to say about statins other than, yes, it sounds like a great idea, but would like to see, I'm looking forward to seeing more data on it. And then ruxolitinib or other JAK inhibitors clearly are very strong anti-inflammatories. I probably wouldn't necessarily utilize them in MPNs simply for their anti-inflammatory properties, because they do have some, there's a risk-benefit ratio in terms of the other side effect profile of JAK inhibitors. But they clearly do have very strong anti-inflammatory effects.
It's definitely a lot to learn before it's ready for clinical practice. Of course, these biomarkers are still in investigation as far as how we can potentially predict outcomes by using biomarkers, which Dr. Hoffman also does laboratory research trying to identify these drivers of progression and markers of inflammation to address with novel therapies and novel drugs. My question to Dr. Tamari, this is a question I sort of made up because I think at some point it will be asked. Right now we have allogeneic hematopoietic stem cell transplant is used potentially curative. What about cellular therapies? So what about giving patients, cells that target the CALR or the JAK2 mutations? Where are we with cellular therapy, and what do we envision for the future?
Great idea. I think we are still quite far from that. The nice thing about that is that once we are targeted specific, ideally the mutant clone, and we don't give all the cells around it, because the whole idea of transplant, right, is we are asking the donor immune system to fight the disease. So if we're able to actually get this much narrow and target whatever we believe drives the disease, theoretically it's a great idea, but in practice we're very far from that.
Thank you very much. So it looks like we.
Make a comment about that.
Okay.
So I didn't review the I didn't review the abstracts. I'll get up so that you can hear me. But there's a really interesting paper at ASH about cord blood regulatory T cells being infused into patients with myelofibrosis. I know that the person who founded that company was a student of mine. So these cellular therapies for myelofibrosis actually might be starting. And surely the immunotherapy parts of this are really going to be taking off in the next couple of months.
Ron, could you repeat the question, please, so we can hear your...
Cellular therapies for myelofibrosis.
Right.
There's going to be an oral presentation on the use of third-party regulatory T cells to improve the degree of splenomegaly and anemia in patients with myelofibrosis. The work was done at the MD Anderson Cancer Center.
All right, thank you to all our panelists for answering these tough questions. We are a few minutes over. In a second, Dave, I'm going to call on you, but I do want to encourage everybody, because this is the end of our plenary sessions, and some of us may not see each other for the rest of the day because we're going to breakout rooms after the break. CRNT has, as you know, has been doing this event regularly. We'd like to do it annually, but sometimes we do it every 2 years. So if you're not registered for CRNT, please do register for the mailing list. You'll get all the updates on when we're having our next symposium. I personally think this was a very successful symposium with an amazing attendance here, and our speakers did an absolutely terrific job, really kind of breaking it down for us and explaining what these diseases are and how they're treated.